Good morning, everyone. It is a minute or so after 10 o'clock, so we will go ahead and get going because I'm really looking forward to this presentation. My name is Dana Murphy Parker. I am the president-elect of the International Nurses Society on Addictions, and this webinar is approved by the California Board of Registered Nurses for 1 nursing credit. I will be providing you more information at the end of the presentation on how you get your CEUs. This webinar is sponsored by the International Nurses Society on Addictions in conjunction with the Providers Clinical Support System. Funding for this initiative was made possible in part by a grant from SAMHSA. The views expressed in written conference materials or publications and by the speakers and the moderators do not necessarily reflect the official policies of the Department of Health. The overarching goal is to train healthcare professionals in evidence-based practices for the prevention and treatment of opioid use disorders, particularly in prescribing medications, as well as the prevention and treatment of substance use disorders. So I am really delighted to introduce you to our 2 presenters today. The first I'll tell you about is Dr. Aimee Techau. Aimee is a psychiatric and addictions nurse practitioner with over 10 years of leadership experience. Her background in nursing includes public health, mental health, and addictions nursing. She possesses broad knowledge in treating individuals with substance use disorders and those with multifaceted mental health diagnoses in both outpatient and inpatient settings. She has special training and certification in therapy strategies for trauma, motivational interviewing, and solution-focused therapy. Aimee is currently a senior instructor at the University of Colorado in the College of Nursing, teaching both undergraduate and graduate mental health nursing, and is the assistant medical director at All Health Network. Her clinical and research experience includes creating and implementing new evidence-based guidelines to low barrier approaches for mental health and substance use treatment in integrated care settings to reduce stigma and improve access to care. She is also a grant recipient from the National Institute of Drug Abuse and the American Association of Colleges of Nursing to educate nurses on opioid use disorders and medication-assisted treatment. To date, she has trained over 3,000 nurses nationwide as a part of her grant. Aimee's long-term research interests include using trans-diagnostic approach to better explain common causal mechanisms and risk factors for substance use disorders associated with PTSD, and developing treatment and prevention strategies based on those findings. Our second speaker is Dr. Jennifer Place. She is a licensed professional counselor and licensed addictions counselor, currently serving as program manager for the Colorado Consortium for Prescription Drug Abuse Prevention at the University of Colorado and Schultz Medical Campus, where she supports the work of the Colorado MOUD expansion program, which is also known as the MAT expansion program, as well as the Treatment, Recovery, and Affected Families and Friends work groups. Jennifer also serves as an adjunct faculty for the University of Colorado, Denver in the Counseling, Psychology, and Counselor Education program for master's level students. For over 15 years, Jennifer has worked in an array of substance-related clinical settings, including private practice and outpatient treatments, employee assistance, clinical evaluation, prevention specialist, and recovery services development. I am going to turn it over and please welcome with me, Aimee Techau and Jennifer Place.
Thank you, Dana.
Thank you so much, Dana.
You're welcome.
Wanted to share, welcome all of you. Thank you so much. I'm Jennifer Place, and I'm going to kick us off this morning. I wanted to share that neither Dr. Techau or I have any disclosures to share. And we do have some acknowledgements we want to make, though. This is our College of Nursing and our center team that have worked tirelessly on this program really for the last 4 years. And so we want to put shout outs to our evaluation team, our principal investigators, as well as our advisory staff. Objectives, you saw those already. So I'm going to share with you some intentions and background. And first of all, I do have to disclose, or maybe put a disclaimer out there, that we are going to be talking about a lot of Colorado specific programming, infrastructure, et cetera. So I know we have participants today from all over the country, and thank you for being here. One of the reasons we wanted to provide some background of how Colorado is set up and some unique infrastructure that we have. So I'm going to start us off with some of that, in addition to discussing our medication for opioid use disorder programs. And Aimee is going to go into all the clinical, the juicy stuff that most of you are dying to hear about, but I'm going to share with you some of the background up front. So I don't know if any of you are familiar with what's called a collective impact model. This is a public health model that really came about probably within the last decade. It's a public health model that's really designed to create large-scale social change, not just systems change, but social change. It's something that takes a long period of time. So it's, again, still in its evaluation stages, but it's action-oriented like a lot of other public health models. It engages affected individuals with the organizations that can influence change across sectors. So there's something unique about collective impact, is it really is designed to look at interdisciplinary connections across public and private sectors. And so here are the tenets of collective impact work, is that you have to have a common agenda between these public and private community member and agency folks. You have to have shared measurement, mutually reinforcing activities, continuous communication, and you also need to have backbone support. And so the backbone support is really where I work. The Center for Prescription Drug Abuse Prevention. Another caveat, please forgive our use of the word abuse. It is just in our infrastructure names only. So backbone support is what we provide with the Colorado Consortium for Prescription Drug Abuse Prevention. This is an arm of the center, and we are the community engagement arm of that center. And so what we're able to do with this collective impact is try and focus on these 8 principles of practice, and involving folks, and this is Colorado specific. So we are working with individuals and practitioners in the 4 corners of our state and everyone in between, trying to find out who cares about these issues, specifically named to prescription drug misuse and preventing overdose. And we want to find out who cares about this, who has a part to play, and how do we work collectively together. This kind of shows a model of how collective impact works. And if any of you are really interested in learning more about this, I'm happy to share some resources with any of you. My email is listed at the end of our presentation today. But it looks, if you go to early changes, what those look like, continuing to work together, looking at systems changes, and eventually leading to population changes is how the collective impact model is supposed to happen. Here's a great resource on the study of collective impact. Our agency was actually included in this initial evaluation where they studied 25 initiatives across the state. And they did find, as a part of this evaluation, that the backbone and common agenda are the first key steps. So if you don't have a backbone agency to kind of manage the collective impact, all the pieces, all the partners, if you don't have that, it's very, very difficult to move things forward. And of course, in order to get all these folks together, you have to have a common agenda. So you have to have that common denominator for folks to rely on and start from as well. So in Colorado, we are fortunate enough to have a collective impact backbone agency, as I mentioned, where I work, the Colorado Consortium. We were funded in 2013. So we've been in the works for a couple of decades before that, thanks to our leadership, Dr. Rob Valek. But our common agenda that we were able to formalize in 2013 and 14 is to reduce prescription drug misuse and related overdose deaths, which, if you think about it, who in any community in any state can't get on board with this common agenda? So it's pretty universal. And as I mentioned, our community engagement arm is the Colorado Consortium. So we are housed within this larger center within the University of Colorado Anschutz Medical Campus. And as we're housed in the School of Pharmacy, we still are able to draw on the expertise of all of our health partners on that campus. So the College of Nursing is one, which you'll hear a lot about today, as well as the School of Public Health. We have the School of Medicine. We have our pharmacy and dentist schools as well. And then at our neighboring campus, we also have the counseling behavioral health department that we rely on as well. This is what it kind of looks like, a slice of our collective impact model at the consortium. You can see that we have 11 different work groups, which again are bringing these partners from private and public agencies together, individuals, agencies. We have 2 co-chairs that are volunteers for each of these work groups, really to head up the work. And each of these work groups operates independently, with the backbone of the consortium, providing them information, getting them integrated with one another. And you can see here, we're trying to address and have different facets of the prescription drug epidemic, the prescription drug misuse and overdose epidemic really represented here in our state. So some things are very specific to opioids. Others are really more generalizable to overall substance use disorders. And so just, for example, our treatment work group, we have folks doing all kinds of work in the substance use arena, as well as public awareness, but yet safe disposal. If you look at PDMP, which is our prescription drug monitoring program in Colorado, those are very specific or really more nuanced towards opioids. So this just gives you a snapshot of what we look like in Colorado. You can see the boxes at the top. The Attorney General's Office, the Substance Abuse Trend and Response Task Force. There is a subcommittee that we represent as well in our state. So we have a close working relationship with our state attorney general. We also have a close working relationship with the legislature and the governor and support of the governor's office through three terms. And also want to let you know that we have boots on the ground. So here's a snapshot of Colorado and all of our 64 beautiful counties. We have staff of the consortium who live and work in these communities. So they live in one of those 4 quadrants of the state. They are connected with local coalitions, local providers, law enforcement, judicial systems, school systems, you name it. Any grassroots up to county commissioners are external relations strategists, as they're called, are connected in those communities, really bringing the voices of those local communities up to that larger kind of mobile, getting folks connected into the work groups, and then also bringing the information from those work groups and other state efforts down into those communities. So it's kind of a really beautiful ecosystem that we've been able to create here in Colorado. And why this is relevant. We're always looking for relevance, right? Well, because we had this infrastructure already in place in Colorado in 2017, when our state leaders were seeing the epidemic of opioids and the ravages of the overdose epidemic here in Colorado, we were able to bring subject matter experts to the state legislature. We were able to create an interim study committee at our state capitol that was focusing on prescription drugs and other substance use disorders, but we're able to show them, look at what's happening in Colorado. And because our legislators are connected to their communities as well, they were hearing about it from their constituents. So we were very fortunate enough. And also just to look at the overdose rates, this is what we were also seeing in 2016 into 2017. And you can see the darker counties represented here have the higher overdose rates per 1,000 population. And if you don't know much about Colorado, if you look right in the middle, you kind of see Denver, this little tiny little area. If you kind of make a line going north and south from there, that's considered the Front Range. That's on the Front Range of the mountains, of the Rocky Mountains here in Colorado. And you see these other counties spread out throughout Colorado. Most of them, about 3/4 of our counties in Colorado, are rural or frontier, meaning they don't have the population, according to the Census Bureau, that would be considered urban. And when you see those counties such as Huerfano, Los Animas, Route, with numbers, 6, 7, and they're rivaling some of our more populated counties, such as Jefferson, Denver, Adams. Our state legislature was really concerned about our rural and frontier communities being impacted, sometimes in some ways even more so by the opioid epidemic than we are here in the Denver metro area. This is a snapshot of what providers, who's waivered to provide Suboxone in Colorado. These dark red areas, no treatment locations. So when you look at the light areas, that's really where we have our urban areas. So Larimer, Boulder, Jefferson, Denver, El Paso, and Pueblo. But you look at the rest of our state and it is a desert, or it was a desert of providers. So thankfully we had state legislators and state leaders who were interested. They provided $1 million to the center to partner and grow the availability of medication for opioid use disorder. We were able to identify 2 counties and 3 different providers to spread this $1 million to. And there's 2 goals for this program. One, to increase the number of MOUD trained and waivered advanced practice registered nurses and physician assistants. And the second goal was to increase access to medication for opioid use disorder and its accompanying behavioral therapies. Oops, sorry about that. So here's what the structure of the program looked like in terms of administration. You can see, again, that Attorney General, the legislator pieces, that is part of our overall organization, but you also see this advisory board. So the state legislature created a whole statute, put our program into law. They also said that we needed an advisory board to oversee this process. So our advisory board consists of county commissioners in the counties that we're serving. Colorado Nurses Association has to have a representative, the Physician Assistant Association, as well as practitioners. So we've got community leaders and we've got the folks in the boots on the ground in the clinical trenches doing this work as part of our advisory board, and that is statutorily mandated. And you can see here our partners, our primary partners have been the University of Colorado College of Nursing and School of Medicine, providing waiver training, clinical expertise in all the ways that we can't, just with program oversight. And that initial pilot program, so we basically had 1.5 years, this was our outcomes. You can see the light blue bar that shows you the number of patients being served in 2017 before this was implemented. You can see the tan bar, 2018. Once this program, the funding happened, the agencies were chosen, and they were able to increase overwhelmingly the number of patients being served. And these are unique patient numbers. And then in the first half of 2019, because our fiscal year goes from July to June, so from January to June 2019, you can see in that purple bar the number of patients we were able to serve at those locations. Our legislature was thrilled. They said, here's another $5 million. We want you to spend this over the next 2 years. We want you to increase the number of counties that you're helping in the state, because as you saw, we needed a lot of help. We still do in Colorado to increase access in counties across our state. Same goals for the program. We were able to expand services, not just cover 12 counties as was mandated, but 21. We were able to find providers who were able to serve 21 of our counties. And you can see here on this map, it's a little busy, but we were working with 6 and at 1.7 different agencies to deliver these services. And Aimee's going to talk to you about how that rolled out and the complexity of what was happening as we were moving this forward. Just want to show you the results from, again, January 2020 through May. Our program went through June, but we were able to capture data through May. And this was through COVID. And so the fact that we were able to continue to increase consistently from month to month the number of patients being served in these 21 counties was just remarkable. And Aimee's going to talk to you about some of the innovations that were put in place, especially through COVID, to not disrupt folks' access to services and to continue to grow. I mean, the fact that we didn't just see a plateau in the numbers being served during at least the first 6 months of COVID is just remarkable. We look at data by sites. You can see a couple of these locations where they did have a little bit of a plateau in 2020, but through technical assistance and other additional support, they were able to continue to move things forward and increase those numbers eventually. Because of that work, just want to say that we're going to continue this work in Colorado. This last legislative session, we were given $3 million to use on an annual basis. So there was not a 2-year term limit put to this funding. So we anticipate to continue this work in Colorado moving forward. We've added a third goal on top of our first 2 that were mandated in statute. We added a third to increase retention because we know how important that is in terms of outcomes and improving health for folks in our state. We still have a long way to go, even though we've made some great progress. So with that, I will turn things over to Aimee. Oh, and I think Dana might have mentioned it initially, but if you have questions, you can put those in the chat. We also can open up to questions as we wrap up today if we have some extra time. So
I did. I just want to say I apologize. I didn't say that. So I did put a message in the chat to be sure and ask, put your questions there. So thank you.
Perfect. Thank you. And Aimee, I will turn this over to you.
Oh, perfect. And Jen, do you mind driving? I apologize, everyone. My internet connection is a little bit slow, so I'm going to have Jen drive the slides. So I was so thrilled to be invited to come speak because, you know, as a nurse practitioner prescribing buprenorphine, I have really relied on PCSS to inform my care. And I am a CARN-AP, so this just feels so amazing to be able to come and present to all of you. So Dana really wanted to know, where did the College of Nursing fit in this project? And, you know, I have to say that it was truly a multi-team collaboration. And as you can see, one of the major goals was to increase the number of nurse practitioners and physician assistants that were prescribing. And this was so important because research shows that nurse practitioner and physician assistants are more likely to work in rural counties. And what's more, they're even more likely to take the steps to prescribe and to care for this patient population. And so the consortium really recognized that they need to partner with the nursing team. And I think, you know, what I learned was that many of the sites, especially sites that were actually run by physician assistants or nurse practitioners, that they really appreciated having a nurse practitioner as the clinical director and leading the change. So it was nice. They said it was so nice to see somebody in my role instructing and leading, and that they felt like that I really understood. But of course, we didn't discriminate. We worked to increase the number of physicians as well prescribing, but our main focus certainly was on nurse practitioners and physician assistants. So Jen, you can go ahead and go to the next slide. So I'm going to talk more about the program implementation and just really get down to the nitty gritty, because we would love it if this is something that you would want to bring back to your site, that you kind of have the nuts and bolts on how you would do that. And I apologize, my slides aren't near as visually interesting as Jen's, but we're gonna show you one of our toolkits so that you'll be able to kind of see that. But so one of the things that we did, so as Jen said, there was a pilot that then informed the expansion. And when we were lucky enough to get the funding for the expansion, we really wanted to make sure that we were just doing everything possible so this would be a success. And so Claudia Mora, Dr. Claudia Mora and I, she was the evaluator, we went through a customer discovery process or a site discovery process. So we went to the sites that had been in the pilot and we asked them, what worked well, what did you wish that you had, how can we support some of our new sites going forward? And we really got some very helpful themes that, again, then just really informed all of the different work products that we developed and how we kind of structured the implementation plan. So one of the things that we were told is that they felt like that they really needed to not only increase provider education, but the community education, because they felt like there was a stigma. So just to give you an example, one of the rural counties, they had explained to us that they had a stockpile of Narcan, but that in the community they felt like if they were to, distribute that Narcan, it would be like condoning opioid use. And so, they were really keeping that, stockpiled, or, just kind of that tired narrative of, treating one addiction for another in terms of what, Suboxone was. And so they really felt like for the programs to be successful, that they needed community education to really decrease stigma. So that was something that we knew that we had to really incorporate in our plan. And then they also just talked about, coordination of care, connection to resources, not only for the patients, but for the providers. So just to give you an example for the providers, how do I get Sublocade in my clinic? How do I, make Vivitrol a reality? Because we know in Colorado, and for those that aren't in Colorado, we do have some barriers to long-acting injectables because we are a buy and bill state. So, there were some barriers that way. And then the patients, just like, how do the patients get to us? In rural counties, there's a very big broadband issue, or having access to, like cellular phones, that type of thing. And so we really took the time to kind of understand, like, what was this, care coordination issue? What was this connection issue to resources? And then one that we're not going to spend a lot of time on, but they really needed a simpler, more efficient electronic data reporting system, because as you'll see later, we tracked all kinds of data. Some, we were really looking at like cravings and retention and pain and opioid use disorder, but then just, basic outcomes such as, how many prescribers, did we increase, right? So they wanted an easier way to be able to report that. And then they really felt like that they needed support to overcome practice barriers. So, when moving into this space to be able to offer buprenorphine treatment, what clinical guidelines, what does a consent form look like? And one of the challenges that we face too is that we had all different kinds of clinical structures, from OTPs to primary care. And so, how do you implement this type of program into my treatment setting, right? So they felt like, just understanding, like how to overcome some of those practice barriers. And you'll see later that we partnered with the School of Medicine and the It Matters campaign, because they are very helpful in terms of being able to bring in one-on-one practice implementation advice from the person that answers to the phone, to the administrator, to even the provider. So these were the themes. And so this is where we kind of went about, creating like a 4-pillar plan. So Jen, you can go to the next slide. So we really took like a 4-pillar approach, and it'll make more sense as we're kind of going through the slides, but we really wanted to have like leveled education. So, education for administrative staff, for providers, for administrators, and then of course, we heard loud and clear the community. We also wanted to take a very holistic patient approach, and we wanted to eliminate some of those barriers that we heard. And we also really wanted to incorporate the nurse practitioner and the physician assistant and talk about, how they could truly be frontline providers driving this change within the community. And you'll learn in just a little bit. I mean, we had just such amazing success stories. And then of course, streamlined reporting, that was a part of it. And then we just got the sense that what they really needed was just both clinical and technical support, because it's one thing to provide the waiver training, but it's yet another thing to actually then begin practicing, putting it into practice, prescribing, because usually it's taking that leap into practice. A lot of people will complete the waiver training, but then they won't take that next step. And so we recognize that clinical support was going to be very key to having this come to fruition. All right, Jen, you can go ahead and. All right, perfect. So this is just, kind of a nice visual of our pillars and a little bit about what is underneath each one. And I'm going to talk in detail about each one. But so again, for education, we wanted to make sure that not only were we providing the waiver training. So I am a waiver trainer, which again was very unique because there aren't that many nurse practitioners. It's usually a physician that's providing the waiver training. And so not only was it the waiver training to be able to get their buprenorphine license, but also we wanted to just really educate on low barrier, very innovative approaches, because the other goal was to drive access. It wasn't just about getting prescribers, but it was to drive access. And we know that low barrier approaches they not only improve retention, but they also can improve capacity and access. And then we just wanted to, we wanted to just keep them up to date on the latest and greatest, because, in rural counties, sometimes they don't always have access to all of the latest and greatest education. So we wanted to make sure that we were just bringing world-class education. But we just didn't educate on the clinical or the medical aspect, but we also brought cutting-edge psychosocial trainings, motivational interviewing. We introduced different therapy modalities, expert. So again, making it very holistic. And we also worked, we functioned in the way where we were doing constant outreach. So constantly pinging our sites, asking them what training that they needed. Did they need a waiver training this month? We were able to do waiver trainings not only online, but we would go down to the communities. We switched more over to online trainings through the pandemic, but we were available to train as few as 2 providers, but as large as we went down and trained a whole organization. So, constant outreach, seeing who needed to be training, doing it for just a very small amount of groups. So that was very, very helpful. And then everything that we did, from our community town halls, which we'll go into in just a second, to our site-specific trainings, really focused on decreasing stigma and really explaining the biopsychosocial model of addiction, understanding how buprenorphine works. We really wanted to take the time to build that empathy, the compassion in for treating this this population of patients. And then I think one of the most important things that we created was we also created an online toolkit that would be available to sites, administrators, frontline staff 24/7. And Jen and I are going to show you what that looks like. And it's an open access toolkit. But this toolkit was designed and developed based on site feedback. So what would you have wished would have been in one place so that you could have successfully managed your patients? So that was a fundamental piece that we put into play. And you can kind of see some of what was in the toolkit, but again, we'll show you an example. And then again, patient care, we talked about having that holistic approach. And so for a lot of our sites, we had to kind of define for them what a patient flow would look like. And again, we wanted to stress the importance of nursing, nurse practitioners, physician assistants as frontline providers that can be providing this care, that it wasn't just a physician that needed to provide this care. And also giving them, other ideas that, sometimes that behavioral health tech, that nurse could be that first person who does the intake, and then the nurse practitioner, physician assistant doing the prescribing and doing the physical assessment. So we really wanted to shape that. And then one of our directives, again, is we really wanted to drive integrated care. And so what I mean by that is, because I'm a psychiatric nurse practitioner, because there's such a dearth of psychiatric providers within rural communities, we wanted to be able to give our providers basic training, be able to handle basic mental health concerns. And so we did training on that. And as all of you know, polysubstance is more the norm. And so we really wanted to educate, although this was more opioid use focused. Again, we know that a lot of our patients are, using meth or alcohol, and, we can't just, practice in the vacuum. We really wanted to open their eyes. We wanted to make sure that they felt comfortable with the treatments across the spectrum. So for mental health, as well as for other substances. And then we did do a lot of work on overhauling the reporting structure. And as we go into our next iteration of grant funding, we're continuing to just improve that. But we have an evaluator, and that's her primary job. And so she was very forward-facing, just like myself, with the sites. And if sites had difficulty with the data reporting, she was there. And so we moved everything into RedCap. We also heard that it would be awesome for the sites to be able to have iPads. So like when patients are entering data, that some of it could be patient collected, some could be collected by clinicians. And so that's some of what we did. And then we created a tracking system. And then our support, I think, was one of the most robust. Next to the education, I think that was one of the most robust. And so when I talk about support, I'm talking about it, again, a multi-team collaboration. So I'm having support, with Jen and the consortium, and then the School of Medicine, and then of course the College of Nursing, but all of us formed like just this wonderful team to be able to support the sites. But we offered not only clinical support, and I'm going to go more into depth about what that looked like, but technical support, grant support, because we really wanted to make sure that, once the funding ended, that the sites were sustainable. And again, that's another big focus of our next iteration, but we really thought about the end in mind too. And so that was an important thing to talk to sites about, and really helping them to become, savvy business folks that are capable of, running a MAP program. So that was additional support that we were able to provide. All right, Jen. Okay, thank you. So the first thing I just want to kind of talk just again more in detail about what was provided, to when we're talking about this level of education. What did it include? So again, continuous waiver training, both online and within the communities. And not only was I, the nurse practitioner, providing that training, but then also we had different physician providers that were also willing. So through It Matters, and that was through the School of Medicine, they also have a waiver training program. And I don't, for those in other states, they were also offering a very lucrative incentive for providers to be able to get trained and have their waiver. So we were able to kind of capitalize on that as well. So, it was almost like being paid to get your waiver. And so it really was driving motivation. But when we talk about provider education too, we did not limit just to prescribers. At every site, we involved the therapist, anyone that was touching the patient could attend, to get more information. So that was really a hit, right? So it wasn't just the providers. And then we spent a lot of time, monthly, we would do quarterly updates with our sites, finding out like what exactly did they really need tailored to their site. So just to give you an example, we had one community where a lot of the providers were very concerned about diversion. And it was almost to the point where it was hampering them moving forward in prescribing. And so I developed just a specific presentation just about diversion, to just really kind of quell their fears. But then I also made myself available to their medical team meetings. They also had a journal club. And so I was just very forward facing so that the providers in that community got very comfortable, that they knew that they could ask any question. And I was able, in real time to kind of address those concerns. And so, we really looked at like every challenge, like why is this community not moving forward, with prescribing this important medication? So we would try to individually, address some of that. We had another site that really wanted to focus in on motivational interviewing, because they felt like that was something that they were lacking. And so within the toolkit, and as you'll see, we had a world-class online motivational interviewing course developed by a motivational interviewing expert, Dr. Paul Cook. But we also know that sometimes, just on-site trainings can just really increase the energy. So we had another trainer, including myself as well. We would go down and deliver specific motivational interviewing training, with opioid use disorder, because that can set up a whole new set of challenges, especially if maybe the patient was using opioids due to pain issues. And so we were able to address that. We had another site that was a primary care site, and so that brought unique challenges all in itself, like implementing buprenorphine within that setting. And so we again tailored training to each site. So on top of just having basic training, so like training them on low barrier approaches, medication first approaches, but we also would tailor trainings. And I think the sites really had a sense that there was a sense of caring and that we were there to help them be successful. So that was part of the secret to our success. And we made sure that that they had exposure to the innovative practices. So again, like when we first started, even with the second funding, we saw that if they were using buprenorphine, it was more like in a high barrier, making the patient come back multiple times. And so we really shared the knowledge and the research. We did a lot of myth busting. That again, you want to strike while the iron's hot, doing a low barrier medication first approach. We also introduced microdosing, and like I said, dual diagnosis, polysubstance. And then, I think this is very unique to our program, and Jen was a part of this, but we also would train on complementary alternative approaches. Jen presented on nutrition. I do not, as we talked about auricular acupuncture. I'm very big on using genetic testing within my practice, especially looking at the MTHFR genetic mutation and how that relates to cravings and substance use disorder. So we talked to them about that, and we had a lot of sites move forward with some of that. And then again, this whole barrier approach, we recognize that the social determinants or recovery capital was very important. So we did a lot of training on that, and I'll explain more. We talked about ACEs, and then maybe something that you all are not as familiar with is it's called the PACEs. So the PACEs is a more strength-based version of the ACEs, because we do think that maybe that there is some re-traumatization that happens when the ACEs are screened for. And so that was one of the things that we wanted to test, because in this next iteration, we're hoping that maybe we will be able to develop an intervention based on the PACEs. And then, we really wanted to keep close communication with our sites. So again, like that we were just an extension of their team. And so we had a weekly newsletter that went out to enhance communication, and that had, local trainings. It Matters had a great MAC collaborative. And so we made sure that that was advertised, or, PCSS different trainings. That was part of our weekly communication. If we knew of any other additional grant funding, this became very important during COVID, because regulations were constantly changing. And so we wanted to make sure that they were abreast of all that. We had the first time around, we were doing it more kind of ad hoc. But what we recognized is, including myself, because I'm still in clinical practice, as a clinician, it's very hard to, read multiple emails. And so we recognized, and it's just some of the feedback, that if we could just tailor it, we could just do it once, once a week, that they would read it and it would be more manageable within a clinic environment. So, and Jen was very instrumental in helping with all of that. And then, like I mentioned, we had a MAP collaborative run by It Matters, but we were also participating in that. We made sure that the sites were aware. And then within the toolkit, which we will show you in just a second, we also had discussion boards. So we wanted to connect the sites, because, like one site might have a great idea of how they were maybe handling something within their rural setting. And so there were discussion boards that they could reach out to one another. And then again, COVID, really threw us for a loop for a second, but we were able to grow through that, because we really responded. And so we were there for the sites, talking to them about how they can move it to TMAT or TMOUD. So how do you transition from inpatient care to telehealth? And so we provided, state guidelines, and what we knew was, the best practice. We also spent time going through how regulations had changed and how they could implement that. Even we talked through challenges. How do you do the drug screen? One of the neatest things that I think we did, and the providers really said that it mattered to them, was we did do a survey through COVID to see how they were faring. Providers, what did they need? What do they need just to be able to continue? And what we found is that they were experiencing a lot of burnout, and there was resiliency issues. And so we developed resiliency training specifically geared toward the clinicians, and we were able to deliver that. And that really kind of helped to kind of bolster the staff during such a hard time. All right, Jen, do you want to go to the next slide? And I see that there's some wonderful questions coming up, and we will certainly address that towards at the end of the presentation. And then, of course, we wanted to make sure it was leveled, and that it was, that we didn't discriminate, and it was across the board, because it wasn't just focused on the providers, because we knew that the administration was very important. So we were able to talk about practice implementation. We were able to partner with It Matters and help them to bring that in. One of the things that we recognized that was a challenge and that was going to impact sustainability was the billing and coding. So we were able to offer, we brought in an expert, had that trained. And then it was very important that it was an agency-wide training. So even that person that answered the phone, they really needed to understand opioid use disorder to be able to decrease that stigma. And then they felt like too that, from the provider to that person that answered the phone, that motivational interview was very important. And then we'll talk about peer training in just a second, but why don't I go ahead and show you kind of the online toolkit. And then this toolkit was updated monthly, and it was very, very important as we had to kind of survive through the pandemic. So we were able to update that. So you can see, like, you can see the site discussion boards. Jim, do you want to scroll down just a little bit? So, oh yeah, and then, so introduction to staff, you can keep scrolling. You can connect with other recipients, and then just go up just a little, Jen. Just okay. So then, we made sure that this was, not only did it house training, but that it was a repository for anything that they might use in MAP practice or MOUD practice. So you can see all the different recommended screening tools. And so, but besides just doing low barrier, we were also very much about pushing the sites, towards, doing the home induction, because if you think about in rural counties, transportation is a real issue. And we saw this as a way to increase access. So you can see like the SOWS is there, and that's a tool that's used in home inductions. Okay, you can scroll down, Jen. And then there was a part on data collection. Again, I'm not going to spend too much time, but we had videos, we had information, so the sites felt comfortable with that. So this was a toolkit not only for the providers, but also for the administrative staff. And then this was, so we paired with HIT Matters, and we created evidence-based guidelines. And of course, we consulted PCSS tools as well, but we created a flow, and we created evidence-based guidelines. And we encouraged even Sublocade induction for patients and Probuphine. So we really made sure that that the sites had all of that information. You can go ahead and keep scrolling down, Jen. And then, we had clinical checklists, consents, treatment agreements, induction documentation, as you can see. And then we wanted to make it very easy. We wanted everything to be like one-stop shopping. So again, we would say, okay, you've got 30, you're at your year. How do you increase your waiver numbers? They could come here. It gave them all the links to everything that they needed. And then Jen, if you want to scroll up, yep. And then the low barrier approach, we spent some time. Jen, you want to scroll down just a touch? Oh, no, I'm sorry, scroll up just a touch, I'm sorry. Yep. So we, again, we said that the low barrier approach was very important. So we had specific education just on that. But we also wanted to talk to them about, planting seeds. So if they came across someone who wasn't, quite ready, like what did that look like? And so we worked with the public health nurses for, the syringe access programs, and we really educated on how harm reduction is a very important strategy. But, harm reduction also can extend to just how you induct a patient as well. And then we did spend a lot of time working on social determinants. We really incorporated the BARC-10, which focuses on recovery capital, but then also the Prepare, which is a tool, but also a process of being able to address patients' social determinants, because we know that no medication can change a reality, and if there's food scarcity and everything else, then the patient is not going to thrive. And like Jen said, we also wanted to focus on retention, so that was a part of it. And then we did have a lot of information on billing procedures, and we know that there are challenges in being able to deal with insurance companies and get things approved, and the whole prior authorization part. So we wanted to make sure that that was clearly outlined, and that every tool, every form that could possibly be there was there. And then we had patient and family resources. And one of the neat things is that we designed everything in a PowerPoint format that could be changed with the site's logos, so that they could customize everything for their site. And then so I had earlier, I was fortunate enough to get a NIDA grant where I created an online training course on just opioid use disorder in general. And so we were able to actually house that training within this toolkit. So anybody, because some of the sites were very new to just opioid use disorder in general, and so they were able to access and complete that course. And then go ahead and scroll down. And then this is where I was talking about we had a world-class motivational interviewing and expert course within our toolkit as well, so they could access that. And then we wanted to make sure that they had access to all the mentor networks, so PCSS, our virtual MAP collaborative within Colorado. And then we know that there are very special patient populations within opioid use disorders. So we have guidance on chronic pain, and even some of the tools that you would use, like the opioid risk tool, the CALM. And then below that, we, again, strong focus on practice sustainability and marketing. So we had a whole business map plan. We had like clinical, posters that they could print, collateral information that they could distribute within their community. And then scroll up just a little. And then we did focus on patient retention strategies. So we introduced them to contingency management. It was not a requirement through this funding, we're hoping to have an even stronger focus on it next time. But again, we wanted to introduce them to all innovative practices that could help with retention, improve access. And then I think another really neat thing is that we really gathered all the MAP experts within Colorado. So we have a whole module delivered by Kaylin Klee, and she's one of our fabulous MAP experts for pregnancy. So we had pregnancy because we had a lot of sites. Again, like, I mean, there's not a lot of resources in rural counties. So we wanted them to feel comfortable with every type of, you know, buprenorphine patient they might have. Okay, you can go ahead and scroll down, Jen. And then we also know that very comorbid is HIV and hepatitis. So again, this is a very well-known education course developed by Paul Cook and one of our faculty at the School of Medicine. So we made sure that that was in there. And then we're still working on this, and this is going to be for our second iteration, but we are working on more of a therapy toolkit. But you know, we did talk about ACEs and trauma-informed care and group therapy, because that was something that they were wanting, building on post-acute withdrawals. We added that. And then we would house meeting minutes, because I'll explain in just a minute. We did do clinical meetings. And then, so we had the special considerations during COVID. So everything that they might need to know. Go ahead and go. And then we also would make sure that they knew that what were the current MAP waiver training offerings. So, you know, I know that this toolkit can seem a little bit overwhelming, but again, we just didn't want them having to like go search for other sites, that everything was housed under one place, and they can access it through a general link. It was available 24/7. So that was a very important component of our education piece. And then you'll see in just a second, the peer model became very important. Became very important in terms of patients being able to access resources within the communities, breaking down barriers. And so we did a lot of site-specific peer training. So we would train even the peers on the importance of Suboxone, because in my experience, I had experiences where I would be prescribing Suboxone, but then if the peer or if even the sponsor wasn't on board, then they might kind of undo all the work. So we really wanted them to understand the importance of Suboxone. So we did a lot of peer training. And then community education, and Jen wanted me to point out, and I think it's very true, that this took on a whole new meaning with COVID. In the beginning, we had thoughts that, oh my goodness, we're going to do, we're going to go to every community and set up a fair and that type of thing. But what we ended up having to do was just more community town halls with education, promoting site success, myth busting. And then we did invite community feedback on how they thought that the sites could grow their own MOUD practice. All right, let's go ahead and go to the next slide, because I know we're running out of time, so I want to make sure we get to everything. So the focus on holistic patient care, we just wanted to make sure that it was tailored to each agency. We really worked with that. We tried to facilitate the hub and spoke model. So the hospitals being the hub, clinics being the spoke. We really advocated for the NP and the PA to be front line and to do outreach. And so we had nurse practitioners going out in the community and outreaching people within the community. And we really moved from an acute care to a recovery model. So all the education supports, everything was focused on recovery. And by incorporating the peer, we wanted to make sure that the lived experience was represented. We addressed polysubstance as well as mental health. Go ahead and go to, all right. And then, so I think another unique thing that we did, especially during the pandemic with our survey, is that we recognized that the broadband issue, that a lot of times patients didn't have access to cellular phones, and so we were able to get phones into patients' hands. We were also able to supply the sites with PPE. We also worked with in the college and in the school pharmacy to help them establish satellite pharmacies to be able to get long-acting injectables in. And we also did a lot of reimbursement advocacy, although it's still something I'm working on because we're still billed by state. But because we had access to the legislator and the attorney general, we were able to talk to them about how buy and bill hampers, how a lot of these sites can't afford it, and how it really limits Sublocade usage and Vivitrol usage. And so that was really important. And then we talked to them a lot about grant funding for the future, and then, like I said, tablets for each site. And we're measuring recovery through the BARC-10. So that's something that we're using. And then, so the clinical support, so they had access to me 5 days a week. So they could call. they could send an email. So again, getting them over the hump from the training to the prescribing. And then we paired with It Matters, and they had contracted a warm line so that could fill in on the weekend. So if they had any issues, or this was going to be their first induction, they could have that one-on-one support. So that was really important. And then that's why we also developed the toolkit, so that the toolkit was there 24/7. So they knew that they could contact me anytime. But we also had monthly site meetings to go over complex cases so they could learn from one another. We did additional education. And then again, everything was tailored to each agency. And then we made sure that we were very forward-facing with the hospitals, with the different practices. All right, I'm going to go to the next slide because I want to make sure we have some time for questions. And then for technical support, so that was our evaluator. Claudia was there as well, 5 days a week. But I think the other thing that we did that was really unique is that at the end of this iteration, we also did a SWOT analysis with each site, so we could help them, to understand what their strengths, their opportunities, and then we tried to make sure that we were shoring them up in those ways before, because we didn't know if the funding was going to continue. And so again, we found like they needed more information on billing, they needed more advocacy, so we made sure that we had that in place. And we brought all kinds of different, if there was a funder, like we would bring that to our meeting so that they could see if that could maybe be a possible fit, because we were trying to do everything we could do for their sustainability. So lessons learned within rural counties, broadband can be a big issue. Medicaid still remains a barrier within Colorado because of our buy and bill system, but I think we've made some traction. People were unaware and now they're aware, and we're hoping that maybe they will change some of these policies in the next legislative hearing. So, and then every community is unique. If you know one community, you know one community, and that's why we had to do a lot of tailoring. We also recognize that polysubstance is more the norm. The meth crisis is certainly on the rise, and so we didn't want to just ignore that, and that's why we made sure that the providers knew how to treat that as well. And we also recognize, and we still don't have an answer for this, but we're trying, is that the lack of detox services, mental health resources, and one of the things we learned is that public health nurses are the connectors within the community, so you really want to reach out to them. All right. And then next step, so one of the things we're really trying to focus on for our next iteration is we really want to try GBOT, or group-based visits. We want to use more of the Massachusetts model with the nurse case manager model, making sure that they are part of that. Some of our sites were really focusing on jail-based programs, but we really want to make that more of an initiative. We will continue that hub and spoke and low barrier approach. But we're also going to bring, including me, we're going to add to me a family nurse practitioner so that they're also represented. We're going to try more micro-learning strategies because we felt like maybe the toolkit was just too much. We want to bridge the gap for detox services. We want a greater focus on sustainability, and we're going to continue our state advocacy work. So, and that is all I've got. So I think we do have just a few minutes for questions. Sorry, I went a little over.
Thank you so much. That was outstanding, Aimee and Jennifer. Really outstanding. And we do have a number of questions in the chat box. We are running a little short on time, so we might not get to them all, but I would ask you, we'll copy them and send them to you. If you could maybe answer, and then we can send those out as well.
Sure, absolutely.
But let's see. One of the questions is, what do you predict will be the impact on applications for buprenorphine prescribing now that educational mandates have been removed?
Oh, gosh, that's such a complex question. I don't know how to answer. Yeah. I mean, I'm hoping that it actually, spurs access, but I guess just in all the time that I've been training this, I still feel like there is, that fear of taking that next step, that the providers somehow think it's kind of an unsafe medication to prescribe. And we spent so much time focused on, like, gosh, you prescribe so much more dangerous medications like lithium or heparin or even insulin, really trying to myth bust to tell them how easy this medication is. So that's the only thing I don't know. I mean, I just, because sometimes you really have to help that provider take that next step to prescribing. So
here's a very interesting question, I think, comes from Byron Hogate. Can you describe your anti-stigma training and how you measured decreasing stigma?
Yeah, no, that's very good. So I think our anti-stigma training really focused on teaching them that, substance use is very much a biopsychosocial issue, and we we worked on like how what's the neurobiology of it, what's the social, and we brought up the rat park experience. We also really educated on what buprenorphine does, how it increases the extracellular dopamine, heals the dopamine axis, how it prevents self-administration or helps protect against self-administration. So we really drilled down to all those details. And we didn't have a measure for stigma, and I think that's something that we probably should consider for next time. But I think we were just getting feedback from our sites that the communities were more accepting, and just the response that we got when we did the town halls was overwhelmingly positive. So
okay, and this will be the last, and it's a comment from Stephanie Hughes, and it says, the toolkit is absolutely great. How can we access it? I'm a provider in Kentucky, so I wanted you to know that obviously this is Colorado, but it really is something that can be implemented in other states as well, obviously, and probably has, so.
Certainly,
Yeah.
certainly. Yes, absolutely. So, I mean, one of the things I can do is I can make the link available, Dana, so that's something I could make sure that I send to you.
Okay.
And, yeah. And it really is. I mean, it's not just Colorado specific. There are resources in there that would be good for every state, no matter what state you practice in.
We would love to share it on our e-learning platform
Sure.
on our INSA website. So
Sure,
that would
absolutely.
be great.
Absolutely.
That was just really, it was so well done and so informative. Thank you so much for doing it. And while I'm at it, I do want to give out, I loved your boots on the ground slides, identifying the people who are important around the state. And I want to give a shout out to Lindsay Simbai, who is our person here on the Western Slope, and to your director as well, Jose Esquivel, because it was their suggestion that Aimee and Jennifer do this webinar for us. So it just has been really, really very well done. Thank you so much.
Yes.
Well, so I would like to ask everybody to unmute themselves and give Aimee and Jennifer a big round of applause, please.
Thank you. I just want to give a shout out to all the nurses out there. Never underestimate what a dedicated nurse can do. I feel like nurses are the key to turning the tide in this opioid crisis. So
perfect. Thank you so much.
Nope, thank you.
So again, I wanted to let you know about the evaluation. You will be receiving an evaluation link. And then once that is done, you will receive if you're a nurse, you will receive your 1 CEU for this presentation. So if you have any other questions, you can email them to me. I can pass it on to Aimee and Jennifer, but we will make sure, Susan, can we make sure that we do have this whole chat copied so we can get these questions out to Aimee and Jennifer, and then we'll send them out to everybody, because if one person had a question, certainly likely that a lot of other people did as well.
Yep,
so
and
again,
I will,
thank you so much. Okay.
Yep, and I'll answer it tonight, Dana.
Okay.
Thanks for having us.
Thank you.
You bet. You bet. Everybody take care and have a good day.
All right.
Bye-bye. Bye.